Well, among a lot of other things, the pandemic has meant an increased interest in medical ethics and a growing demand for ethical services, as ethical rounds, moral case deliberations, clinical ethical support, and so on. And as I'm an advocate for medical ethics, of course, I think this is appreciated and welcomed. So now let's hope that the pandemic tiredness of being tired of the pandemic-related issues will not afflict the field of medical ethics as well. And let's hope that medical ethics remains medical ethics in the sense of focusing on value conflicts in medicine. According to my personal experiences from the last 3 years, clinicians, so that is professionals in healthcare, have dwelled in some different spaces of views on what are ethically difficult care situations during the pandemic. I will try to describe a couple of these spaces, 6 of them. First, the space of being ignorant and or afraid. In the very beginning, some were rather reckless, others became afraid. In agencies for control of communicable diseases, one often tries not to be alarmistic, an attitude of being a bit laid back, perhaps, and that's, I think, is why one would like to avoid panic reactions. Health professionals wanted to discuss what to answer when questions from patients and friends were posed. How dangerous is this? Will we all die? And ethically difficult situations were associated with not knowing, and it could really be a threat to professional identity to not know, have no robust answers. Also questions about clinicians' duties surfaced. What if I get infected myself? If I pass the virus on to my family, to my patients, to my elderly mother? The insufficient supply of face masks and other personal protection, equipment for personal protection, PPE, quickly became important and very challenging. Eventually, one was recommended to work from home, and this was a recommendation that seldom was an option for most healthcare workers. Second space, the liberated professionals. Suddenly, administrative matters at the hospital went easy and quick. What had been dragged out for months and years in bureaucratic procedures and endless discussions suddenly just happened. Decisions were taken, obstacles removed. At all levels in healthcare, focus was on the real thing, taking care of the patients. Suddenly, the number of meetings to discuss this and that diminished, and the number of data needed to be entered for statistical reasons to follow up production and quality of care diminished as well. This was sometimes due to formal decisions that we make a break during the pandemic, but often it was just vanished away as part of silent agreement. You will be forgiven for not doing this because there is a pandemic. Eventually, at least some physicians felt that now I'm doing what I actually was meant to do and what I'm trained to do. Doctors felt listened to. Decisions were moved down to the floor where the care took place. Staff at the administrative levels, often before the pandemic, seen as troublemakers and just there to complicate things, sometimes were perceived as and functioned as service and support for the clinical staff. Ethically difficult situation, at least perceived as difficult for someone acting as a clinical ethicist were, on the one hand, to acknowledge that the basis of a physician's professional ethics is to heal the wounded, so that's fine, that was what we were doing. On the other hand, trying to moderate the overconfident manifestation of this liberation. A number of websites and chats on the web were introduced on clinicians' own initiatives, where experiences were shared and best ways of treatments were discussed. The official channels run by authorities were not at all that quick-footed as these initiatives from the floor. To stick to sound scientific skepticism was sometimes hard. Articles were pre-published before the referee procedure, which indeed puts high demands on the readers to take a critical stand. Research ethics was also speeded up. If the applicant could argue for that research project was related to the combat of COVID-19, sometimes rather distantly related to this, shortcut was offered, which meant examination and in many cases acceptance of the project within a fortnight, which was very, very fast compared to ordinary situation. Third space, the heroic space. It was nice being almost a hero. Media and public response were in many cases very supportive. Thank you for what you are doing. One side of the heroic position emerged in reasoning of bilateral duties, perhaps reciprocity. If we, as physicians, work so hard for the benefit of the citizens, what can we ask from the citizens? The least is that people obey recommendations to keep distance, to stay home, not to go to nightclubs. Perhaps recommendation ought to be transformed and sharpened to mandatory legislation. Why not fine people gathering in the streets? Ethically relevant was to recall that the capacities of ordinary people differ. Some have good opportunities to reduce the risks of infection, others have not. This was even more accentuated when vaccines became available. My intensive care unit is full of severely ill COVID patients. The patients worst off are all not vaccinated, the ICU doctor said, and he or she continued, it should be a duty for everyone to be vaccinated. Although Sweden subsequently reached a high level of vaccination in the population, and although no prominent anti-vax movement occurred, some were hesitant. Also staff members at hospitals and the staff at nursing homes for the elderly. The council Smer stated that it was a moral obligation to get vaccinated if you work with patients, clients susceptible to serious COVID infections. Some unions and some HR departments frowned and was not very happy with this, but managers agreed. And I still think that this standing holds in a moral sense, albeit perhaps not legally. Outspoken media attacks on the authorities from more or less excellent experts added to the situation. The official strategy to combat the virus was deemed insufficient, hazardous, and unscientific. Lockdowns were recommended, and schools still being open was described as a scandal. Clinicians sometimes struggled with the conflict between speaking out their own opinion and being a good civil servant, adhering and defending official policies. We discussed if clinicians ought to restrict themselves as members of the privileged medical profession. It is a matter of balancing between freedom of speech, which all are entitled to, and sticking to a professional duty as to avoid advocating personal attitudes and ideas not based on evidence. As a rule, societies profit from a freely expressed diversity of opinions. Certainly, today's Russian society would benefit from this. But public health measures might as well be hindered from confusing and contradictory messages from experts, especially if the quality of these experts' expertise is hard to judge, at least for the general population. Number 4, space of being in need of help and guidance. In contrast to the liberated professionals' feelings of self-efficacy, a search for guidance evolved. Facing the challenge to prioritize patients for intensive care when the demand threatened to exceed the supply, then guidance was asked for. The physicians in charge of doing this was facing a genuine ethically difficult care situation. And ethical guidelines were produced in high speed and delivered from the National Board of Social Affairs and Health. And the discussion followed. Was the official guideline an example of utilitarianism contaminating the legally founded platform for priority setting in Sweden? An interesting observation is that the guidelines explicitly was valid only if the demand for intensive care was impossible to supply for, which perhaps actually never happened. All the same, the guidelines from the board inspired the formation of local guidelines with a much wider range of applications. Number 5, space of being tired and worn out and angry. As a probable consequence of work overload during an extended period of time, in combination with no clear goal line when troubles can be assumed to be over, the level of conflicts among clinicians has increased. The content of meetings to discuss ethically difficult care situations have often turned into discussions on conflicts between units or between different staff categories. The clinical ethicist might become a counselor or an amateur group therapist. To clarify ethical conflicts in the light of principles and theories is more or less useless. Although the practice of medicine is an ethically laden practice, not all stress perceived by the healthcare professional is moral stress. Quite ordinary stress because of overwhelming workload, insufficient resources, or weak organization also exist. The clinicians are angry and frustrated, not least as the employer, the region, sends messages on the need to cut down costs and to rationing care. In this space, the clinical ethicist might better be replaced with adequate competence. And I not agree that the resources isn't a problem. I think resources is a problem in that sense. And number 6 and last, the space of system must change. A vivid debate on the need of fundamental reorganization of the entire healthcare system has emerged as a result of criticism of how the COVID pandemic has been handled. A profound reorganization, even suggestions that the Swedish healthcare should be nationally organized, which sometimes is described as the only way forward. Any organization must, of course, incorporate the basic values of medicine. If a national health service or a regionalized health service is better equipped to do this, it's not an easy question to answer. My own humble comment is limited to that it is important to remember that reorganizations consume a lot of energy and that the aim of the undertaking is often obscured during the process. Well, the COVID pandemic has emphasized the need of discussing medical ethics in many aspects of medicine and healthcare system. Let's hope that the discussions during the pandemic might mean some substantial achievements now as we are returning to the normal. Thank you.
I will ask you too, and probably a very impolite question.
We have been talking before, so
Yeah.
we could foresee this.
It's about the heroic space.
Yeah,
Looking
you
at
like it especially, I think.
looking at this in, say, 50 years perspective, will we say that there are, of course, heroes and there are people who are less heroes, but will we say that the healthcare workers as a group were all heroes?
No.
Because if I look at the pandemic from my perspective, and you mentioned administration, it disappeared. I know number of administrators working 24/7, trying to get things work, and we don't call them heroes. They are the problems. I'm just curious how the rhetoric is working here,
Well,
but I'm not fair.
And not to mention all philosophers working 24
But
hours.
that's just a pleasure being a philosopher.
Yeah. Yeah. I actually, of course, not all are heroes, were heroes. Perhaps no one was a hero, but what I was trying to describe is the ambience, the thinking, what was in these spaces, which was not spaces actually in a historical sense, but surfaced in the discussions which were meant to was about ethically difficult situations. So. No, the answer is no.
Thank you.